She is from Kozhikode Medical College. The topic is adult onset nephrotic syndrome. I would like to invite Dr. Jacob George. Sir is a retired professor and HOD, Government Medical College, Trivandrum. Presently, he is a consultant nephrologist at Cosmopolitan, SUT, PRS, and SK Hospital. I would like to invite Dr. Vineetha Madam. Madam is Associate Professor Nephrology at Paripalli Medical College, Kollam.
Gopika, go ahead.
Good afternoon. I'm presenting a case of adult onset nephrotic syndrome. So my case is Mr. Balan, 62-year-old male from Kozhikode, who is a manual laborer. The presenting complaint is 5 months duration. History of present illness. So the patient had a swelling, presented with a swelling of both feet up to ankle. That was initially noted 5 months back, which was insidious in onset and symmetric in nature, and which was gradually progressive, and it reached below the knee in around a 2 weeks duration. It was also associated with the facial puffiness, which was initially noticed around the periorbital region, more during the morning hours and later decreased as the day progressed. And it was also associated with proteinuria. He did not give any history of shortness of breath, orthopnea, palpitation, syncope. There was no history of jaundice, abdominal distension, altered bowel habits, no hematuria, oliguria fever, no history of any EC fatigability, loss of weight, loss of appetite, bony pains, bleeding manifestation, no postural giddiness, numbness or tingling, skin rash, joint pain, no history of cough, hemoptysis, lower urinary tract symptoms, and also no history of any NSAID intake or indigenous drug intake. He was evaluated in a local hospital and he was found to have a protein leak in urine, which was initially said to be around 4+. But his blood pressure was found to be normal on evaluation. Creatinine he remembers to be 1.2. And on further evaluation, he was found to also have a high values of cholesterol levels. He was later started on a intravenous and later oral medications to relieve edema. And a costly blood test was done for evaluation of this, and it was found to be negative. Later on, he was undergone a renal biopsy. There was no post-biopsy complications. And he was also done some blood test, scan abdomen, chest x-ray. It was said to rule out secondary causes, which was also found to be normal. Later on, edema subsided. He was continued on oral diuretics and other medication to reduce the protein leak, which in one of the drug included telmisartan, as he remembers. There was no history of any costly oral medication intake or any tapering dose of any drugs were not started. And during the monthly follow-up for the initial 3 months, he was asymptomatic, he was compliant with the drugs, and he remembers his urine protein was reduced to around 1+, and his blood protein levels was also said to be improved. Creatinine was around 1.2 to 1.4, and after seeing the biopsy report also, he was continued on the same drugs. But 2 weeks back, he again developed a similar episode of pedal edema and proteinuria, which was again not associated with any oliguria, hematuria, dyspnea, exertion, and also not associated with a fever, cough, sore throat, dysuria, and GI symptoms. And again on urine testing, he was found to have a 4+ urine. And he was here in this episode, he was said that he was losing around 9 grams of protein in urine. His creatinine was increased to around 1.4. Blood pressure was normal. He was again managed with intravenous diuretics, and he symptomatically improved within the initial 5 days. And due to the worsening of this protein leak, he was advised on starting a costly intravenous injection, which was given once weekly which has to be given once weekly for 4 weeks under intensive care unit. And now currently he is admitted for the first dose of the intravenous drug. He has no edema at present. He is currently on oral diuretics and still has a 4+ protein leak in the urine. There was again no history of any gross hematuria, flank pain, asymmetric limb swelling, dyspnea, abdominal distension, pain abdomen, headache or seizures. So coming to past history, there is no history of any diabetes, hypertension, coronary artery disease, cerebrovascular accident, COPD, pulmonary tuberculosis, no history of any rheumatological diseases, hepatitis, blood transfusions or allergy, no history of any over-the-counter medication intake or indigenous drug intake. Personal history, he takes a mixed diet, normal bowel and bladder habits, normal appetite and no addictions. Family history is married with 2 children, mother was hypertensive, no renal disease in the family. So coming to the summary, Is a 62-year-old male with no prior comorbidities, presented with pedal edema and facial puffiness of 5-month duration, found to have proteinuria and dyslipidemia, managed with diuretics. A costly blood test, probably anti-PLA2R antibody, and few other investigations to rule out secondary causes were done and was found to be normal. Renal biopsy was done, was given diuretics and antiproteinuric measures. Symptoms and proteinuria improved on follow-up. But he had a similar episode 2 weeks back with a worsening of proteinuria, for which he's been planned for giving a once weekly IV injection of a costly drug for 4 doses. So diagnosis, adult onset nephrotic syndrome. My first diagnosis, membranous nephropathy, probable primary, which comes under KDO high risk category on injection rituximab. My differential diagnosis is secondary membranous nephropathy and primary FSGS.
The physical examination? Physical examination?
Examination. Patient is conscious oriented, moderately built and nourished.
Positive findings you say. What all positive?
He does not have edema at present.
No edema.
No edema at present.
Blood
No
pressure?
pallor. No lymphadenopathy.
Blood pressure?
Blood pressure is 130/70 and lower limb it's 140/90. JVP is not elevated. Skin, there is no abnormality. Nail is also normal. No thyroid swelling. Fundus is also normal. System examination also, there is nothing significant.
So no evidence of anasarca. You said there's no
No,
edema.
now his edema has completely improved.
Okay. All right. So what do you think he has?
My first diagnosis, he is having adult onset nephrotic syndrome. So my first diagnosis,
Again, why you said nephrotic syndrome? Because you said there's no edema, no hypertension.
he
anything,
5 months back he presented with edema, and he had a pedal.
How was that edema? Was it a?
It was insidious in onset. It was gradually progressive. It was symmetric in nature, and
was it just confined to the legs and face, or was it?
initially he had
Was there any-
edema over his bilateral
No
lower limbs.
ascites, pleural effusion?
No,
nothing?
ascites was not there, but periorbital puffiness was there.
Okay.
And then
So I think you can say that he had hypercholesterolemia, but hypoalbuminemia is not very striking.
initially he doesn't remember that value, but later on during follow-up he said that the doctor said his protein level has improved.
So clinically, how you will diagnose nephrotic syndrome?
Clinically, the initial symptoms will be the patient will be presenting with edema. Initially, pedal edema, periorbital puffiness will be there. It can progress to having ascites also. And in case of nephrotic syndrome, he may have noticed a proturia. And on evaluation, we can in the urine testing, there will be dipstick testing, proteins will be present. And if it is nephrotic syndrome, the protein levels with the protein levels we can diagnose nephrotic syndrome. If it is
Generally, the definition of nephrotic syndrome is massive proteinuria. No? Okay, you said there's one report.
Clinically,
you said, massive proteinuria.
more than 3.5 gram per 24 hours. Along with that, either hypoalbuminemia, that is less than 3 gram per deciliter, or if albumin is not there, we can diagnose the presence of edema.
All right. Now, what do you think of you said membrane? So, I think you can classify this as possibly he's got nephrotic syndrome based on the hypercholesterolemia. The edema is not very massive, no? And you don't have any
Initially-
hypoalbuminemia, you didn't have any blood pressure, raised blood pressure, and you
Blood pressure is
didn't,
normal.
didn't have any hematuria. Okay.
No.
So, how you, suppose a person comes with frothing of urine, how you differentiate whether it's a tubular proteinuria or glomerular proteinuria?
Based on the level of protein, if it is a dipstick, usually the tubular protein will be less than 2 plus only. And glomerular level protein, nephrotic range proteinuria, maybe it will be around 3 plus to 4 plus. You can also see the urine protein creatinine ratio, albumin creatinine ratio, and 24-hour urine protein. If it is less than 1 gram, mostly the tubular proteinuria. If it is more than 2 gram, it will be glomerular proteinuria.
All right. So now when a patient comes with, because you already, an adult patient at the age of 64 coming with this type of a nephrotic type presentation without much of a, the protein is not very significant. No, now it's not very significant, no hypertension. What are the differential diagnoses you have?
Here in
I know before going to that, let us say, I mean, here, I think you can classify it for the, because some examiners want you to say that the syndromic presentation, you say it's nephrotic syndrome, you can just classify it again like nephrotic syndrome. What do you think? Is it what do you think is likely glomerular etiology? Before going into membranous, you can just have some broader classification.
could be podocytopathies.
Yeah, before that, you can say it's adult onset nephrotic syndrome, you can classify that. Is it due to a primary glomerular disease or secondary glomerular disease?
It is here, there is no other, for my patient, there is no other symptom suggestive of a secondary glomerular disease. So most
Okay,
like
which secondary glomerular disease can present at this age?
Secondary, this type of presentation may be seen associated with a multiple myeloma,
So
amyloidosis.
plasma disgrace also is there. No?
Yes.
So here there are no features of backache, no history of
No,
loss of
no
weight. So you say that this person, do you think this is a proliferative glomerular nephritis or a non-proliferative?
Patient does not give history of hematuria, hypertension.
No hematuria at all.
No hematuria,
Okay,
hypertension.
so you can say this is an adult onset nephrotic syndrome. I would like to consider as a non-proliferative glomerular disease. Of the non-proliferative glomerular disease, I would like to consider primary glomerular disease, of which you can say the differential diagnosis. You put membranous considering the age. Okay, membranous that you put it a high considers the age. What are other primary non-proliferative glomerular diseases which can occur at this age?
Here
60-year-old man.
I
You
can.
put membranous first. Then next.
Next, I'll put primary FSGS, but here in the age group usually occurs in the 18 to 45 years of age, but it can present in any age.
Okay.
But here the point against is that the patient had an incidence on onset of proteinuria.
Okay.
But in primary FSGS, usually patient present with an acute onset proteinuria may be associated with hypertension, hematuria, and renal insufficiency.
Okay.
But it was
Okay.
not in this
All right.
patient.
So you said membranous first. You brought FSCS. Any other?
Secondary membranous, because at this age he's a
No,
male
any
patient.
primary?
In primary, MPGN can also be kept as a possibility, but less likely
Less
in this
likely.
age group.
Okay.
And again, it could be associated with any monoclonal gammopathy. Then cryoglobulinic, that's second.
Okay. Any other primary glomerular can occur?
MCD, adult onset MCD can also be kept as a possibility.
Okay. You bring that lower, but still a possibility, no? Okay. What about IgA nephropathy? Can that present as nephrotic? Somebody was mentioning about IgA nephropathy less than 5%. What is your comment? Have you seen nephrotic IgA presenting as nephrotic?
Yes, sir.
Can theoretically occur?
Can present with
So you
it.
bring that also. So IgA nephropathy, MPGN will put lower down the list because not much of hematuria, no? Then secondary diseases. So the secondary disease at this age, a 65-year-old person with proteinuria, secondary glomerular disease, what are the likely possibilities? One you
What?
said multiple myeloma.
Plasma cell dyscrasia, yes.
Good.
Then it could be as cryoglobulining vasculitis is one possibility around 60 years of age. And then hepatitis B, C related diseases. Then autoimmune is less likely, but can be associated with rheumatoid arthritis, but our patient doesn't have any symptoms of that.
Okay, some other nodular glomerular diseases, fibrillary glomerular nephritis,
Fibrillary,
even diabetic nephropathy, sometimes you see as a surprise, no?
Yes, sir.
They may not have the history, but then suddenly you find lesions. So diabetic nephropathy also, the history may not be there, may not be very striking. So this you can consider as secondary disease. So here of these you will likely to consider a primary. Now we'll just go each one by one. Huh?
Yes.
So we'll first put minimal change disease. You said it's rare in adults. We agree. So what is the percentage of minimal change in nephrotic syndrome in childhood? What is the percentage having minimal change in adults? How much should be?
If it is less than 10 years of age, around 90% of the patients with nephrotic syndrome,
So
it
childhood
will
nephrotic syndrome, 90%
be
minimal change.
MCD.
In adults, how much will minimal change?
Around 10 to 20 years, around
5 to
50%, and more than 20 years, around 10 to 15%.
Alright, good. What are other differences in minimal change disease present in adulthood compared to pediatric? What are the differences?
In minimal change, as compared to the children, the patients will be responsive to steroids, but the duration of steroid will be more prolonged duration will be required for the adults, because
What about the response to steroids? The same as in pediatric or different?
no, it is less responsive.
How
And
in pediatrics, what is the percentage of response to steroid?
if we are giving steroids, the usually patients around 50% will respond by 7 to 10 days. And we can give up to 4 weeks to prevent the further relapses. But
So
in
around 90% will respond, no, pediatric.
Respond, yeah.
In adults?
adults, around 50% will respond in the initial
That
4
around-
weeks.
little less, 30%. And when will you, is there a difference in the definition of classifying as steroid responsive, steroid resistant in pediatric versus adult?
That is, we have to assess the response after giving 4 weeks in case of children, whereas in adults we have to give a minimum of 4 weeks, can extend up to a maximum of 16 weeks.
Okay, so the duration of saying steroid resistance is different. In a pediatric, 4 weeks, after 4 weeks, you probably consider steroid resistant. We can say late responders up to 6 weeks.
Yes.
Whereas in adults, probably 8 weeks, you say steroid resistance, and you say, probably steroid not responding. By 12 weeks, if it fails to respond, you consider it as not response. So the duration is also slightly less. Okay, then what about the complications in pediatric minimal change and adult minimal change? What any difference?
And regarding the complication, thromboembolic complications will be less in case of children, but if it occurs, it will be more severe, and arterial thrombus is more in case of children. And infections also, it is more in case of children as compared to the adults.
Okay. All right. So any of the complications is more likely in adults other than thrombotic complications?
Dyslipidemia, Then
Childhood nephrotic syndrome means dyslipidemia.
AKI, acute kidney injury, is more common in
Good,
adults.
more common. What are usual causes of AKI nephrotic syndrome?
One cause is that there will be intravascular depletion because of the reduced oncotic pressure, so reduced renal perfusion. Second cause is because of the tubular protein cast that is present, which causes the intertubular obstruction and decrease in the filtration pressure. Then third is can occur because of any renal vein thrombus. Then fourth is because of the use of diuretics, which can cause acute interstitial nephritis as well as prerenal depletion. Then fifth is because of infections, which can end sepsis, which can again cause acute interstitial nephritis.
What is nephrosarca?
Because of the interstitial edema that occur along because of this nephrotic syndrome, it can cause compression of
blood
the
flow. No? So these are the usual causes of AKI, which is also more common in adults compared to children. You said mention about the thrombosis. No, so why? I mean, what are the reasons why patient nephrotic syndrome develop hypercoagulability?
One is that there will be loss of the anticoagulant factors in the urine. Mostly the antithrombin 3 and protein C will be lost in the urine. So the levels of this antithrombin 3 will be reduced as much as 2 to 3-fold. Second is that because of the loss of protein in the urine, there will be a compensatory hepatic oversynthesis, and this will cause the oversynthesis of the procoagulant factors like factor 5, factor 8.
Right. Other than coagulation, what are the other complications nephrotic syndrome can have?
One is acute kidney injury, second is infections.
Then why infection? What type of infection? And
Infections because there is loss of immunoglobulins, complement factors and opsonins in the urine. So there will be more risk of infection with encapsulated bacteria, and also because of the edema they are more prone for the cellulitis. Because of ascites they are more prone to peritonitis.
why exactly is the encapsulated organisms more likely? What is
Because
the
of the opsonins, that is
what does that do? Why opsonins is predisposed to encapsulated organisms?
because its opsonins are required for the phagocytosis of this encapsulated bacteria. So when this opsonins are lost in urine, there is more that it will be not removed.
All right. Any long-term complications of nephrotic syndrome?
Because of this dyslipidemia and other thromboembolic complication, patients is more prone for having a cerebrovascular disease, coronary artery disease, and progressive atherosclerosis also.
Any other long-term complication? Especially in children, nephrotic. Malnutrition. They lose a lot of protein. So malnutrition is also common. Loss of protein. All right. Now we have said that minimal change disease. You have done a biopsy on this patient. This comes as minimal change disease. And in addition, there's IgA deposition also. There's a comment.
IgA along with MC.
Minimal change disease is the light microscopy, but on IF they showed IgA deposition.
IgA, if the clinical picture is similar to MCD, may not be always significant. Can have an lanthanic IgA deposits also.
Good.
And
Yeah, so because generally IgA nephropathy expects mesangial proliferation, so these people may not be asymptomatic. How do you actually diagnose lanthanic IgA? How you can prove that this is lanthanic IgA?
there will be no mesangial proliferation expansion will not be there, but in immunofluorescence we can see.
Regarding the IgA, is any specific characteristic of the pathogenic IgA and the lanthanic IgA?
The type of IgA, polymeric IgA, the galactose deficient IgA1 will be more seen in the pathogenic IgA.
Okay. All right. But then there's a monoclonal antibody which you can use, no? KM55, no? Specific of the pathogenic IgA will be negative here. Okay. All right. Then you said about focal segmental sclerosis. Okay, focal segmental sclerosis. Okay, how would you say that this is likely to be primary FSGS or secondary FSGS? In adulthood, which is more likely, primary or secondary?
Both can be there. Primary FSGS can occur at any age. Secondary, usually there will be an underlying process. So in primary, usually present with the nephrotic syndrome, and patient on light microscopy, we can have any FSGS.
Clinically, how you differentiate primary and secondary FSGS?
Sudden onset of proteinuria with massive proteinuria presenting with nephrotic syndrome is most likely primary FSGS. But the secondary FSGS usually present with a subnephrotic range proteinuria, not usually present with a nephrotic syndrome. And also the other associated features may be there in secondary FSGS, like maybe associated with hypertension, obesity, can have a associated nephron loss or infections.
Clinical examination, yes, clinically alone. Can you say this is more likely to be primary, this is more likely to be secondary?
Edema, if it is present, is primary FSGS.
Okay. Biopsy wise, how it will?
In secondary FSGS, more likely a perihilar pattern of FSGS, and glomerulomegaly will be there. And in case of electron microscopy, the secondary FSGS will have a segmental food process effacement, whereas in primary it will be a diffuse food process effacement.
Okay, good. You were mentioning about the, okay, then next we come to the second, so now the secondary glomerular diseases, no? I mean the secondary. So secondary we said you will consider both plasma dyscrasias as a possibility here. Okay, now could this be a nephrotic presentation? Because you are not seeing the urine microscopy. Now the person didn't have macrohematuria, but he had, let's say he had nephrotic range protein with microscopic hematuria. Then what all would be the possibilities?
MPGN is one possibility, and MN, even if it is membranous nephropathy, around 30% patients can have hematuria and other presentations. Then FSGS again another possibility, nephrotic. And secondary other causes like autoimmune diseases.
Okay, then you have seen some patients coming with the diagnosis, the histopathological diagnosis, minimal change disease. And sometimes the pathologist gives a diagnosis, this is minimal change, but FSGS cannot be excluded. When would he write? What decides that this is minimal change and he says this is minimal change, but we cannot exclude FSGS? Why he makes a difference? What essentially?
Because in minimal change disease, there will be the light microscopy will be normal, but FSGS we need around.
Yeah, they've said that it's showing the minimal change, but he has written FSGS cannot be excluded. So what made him prompt to write that?
Maybe some interstitial fibrosis or tubular atrophy may be there, and may have some associated glomerulomegaly that may give clues for the FSGS. And also the juxtamedullary nephrons has to be there, and more than 22 glomeruli has to be there to rule out FSGS. So if the biopsy is inadequate, if IFTA is present, glomerulomegaly is present, then we can completely rule out.
Which glomer? Okay. All right. So you had mentioned about this. Now, how will you approach this patient? What investigations will you do? This patient has come with mainly frothing of urine, not much of edema, no hypertension, no hematuria. How will you proceed to investigate?
First, we will do the urine microscopy.
From the urine microscopy, is it possible to say that this is nephrotic syndrome?
If it is more than 3+, 4+ nephrotic range.
Microscopy.
Can have that fat body, oval fat bodies can be there.
Fatty gas more likely. Okay. All right then.
Then urine microscope, then urine dipstick can be done, 3+ or 4+ protein. Then urine.
Okay, why you are very keen to do dipstick?
Sir?
Why you are very keen to do dipstick in this patient? You said that he came with a 9.9 gram protein urine. No?
Yes. Sir.
Why you are very keen to do dipstick? Why do you want to do dipstick or 24-hour urine protein using sulfosalicylic acid?
It's better to do urine protein creatinine ratio or albumin creatinine ratio.
Which one you want to choose? You want to do sulfosalicylic acid 24-hour in protein, or you want to do dipstick, or you want to do both?
In this patient, since it's an elderly age, the other may not be always albuminuria, can have other proteins also.
So you do a dipstick also, because if he's having a proteinuria which is 9 gram, but dipstick is negative, and this could suggest what?
Non-albumin proteins may be there.
Like
multiple myeloma could be one
possibility.
possibility.
In this, so that's why you do both. Then okay, so you've done the urine examination. Then what else?
Then we have to do the routine biochemistry has to be done.
Before that, biochemistry, do anything else?
Before
biochemistry, hematology?
Hematology. First we have to do the hemoglobin analysis. If it is anemia is there, again there is a possibility of plasma cell dyscrasia, then secondary malignancy.
Hemoglobin ES are important, no? In this patient. All right, then?
Then we have to do the renal function testing, we have to do. Then we can do the other serology we have to do, like anti-PLA2R in this case, then
so
C3.
Is it possible to diagnose membranous without a biopsy?
Yes, if the anti-PLA2R is positive, then there is no need of
What's another peculiarity of membranous nephropathy with regard to biopsy? Doing a biopsy to diagnose FSGS, to diagnose IgA nephropathy, MPGN, and membranous, what's the difference in the biopsy?
In membranous nephropathy, it is a uniform
what's the advantage
process.
of a biopsy in a membranous?
Single glomeruli is only required for membranous nephropathy.
All the others you require multiple. Here, even if the single glomerulus shows the membranous range, it's diagnostic. Okay. Now, you said that this patient came with massive edema, and you gave some other, rather than going for immunosuppression, you gave some other drugs. So what are the drugs which can use to decrease proteinuria?
So primarily there is non-pharmacological treatment and pharmacological treatment. From non-pharmacological, first we have to reduce the sodium intake to less than 2 grams per day. Then we have to control the advice regarding the weight loss. Then we have to go for the drugs like for the BP reduction. We have to keep the blood pressure less than 120/80.
What are the drugs
And
which, that we agree. Now
and
you
if-
say the non-immunosuppressive drugs, which you can use. The non-immunosuppressive drugs to decrease proteinuria.
AC inhibitors and ARBs, then SGLT2 inhibitors, mineralocorticoid receptor antagonists, endothelial receptor blockade. Then we have to go for
Any calcium channel blocking can decrease proteinuria.
Cilnidipine is found to reduce proteinuria.
Nephrotic, all this, sometimes some proteinuria. Which calcium channel blocker is recommended in diabetic nephropathy?
Not sure, sir.
Difference between dihydropyridine and non-dihydropyridine. Is there any difference? What are non-dihydropyridine calcium channel blockers?
Verapamil and diltiazem, but it is not found to reduce proteinuria.
Yes. Compared to calcium channel blockers, non-dihydropyridine. That is formerly it was used, now it's gone out of fashion, but non-dihydropyridines are used. Okay, now this, what are the indications for giving albumin? You said you gave albumin, no?
No,
Okay.
he
What are
doesn't
the
say.
indications for giving albumin in a patient with nephrotic syndrome?
One is if the patient is having any intravascular volume depletion, severe intravascular volume depletion, if the albumin is less than 2 gram per deciliter, if there is any sepsis, if the patient is having infection and sepsis, and prior to giving the diuretics, if you have to correct the intravascular volume.
How does albumin help in increasing diuresis? How does it help?
Because the albumin increases the oncotic pressure and which will cause the shift of fluid from the interstitial space into the intravascular space. So more of intravascular space, so that when we give the diuretics, the volume depletion can occur.
Does it have anything to do with pharmacokinetics of the diuretic?
Because
albumin.
for the diuretics are usually bound to the plasma, I mean proteins.
So what happens in
for the-
hypoalbumin when you're giving a diuretic?
because if the level of protein is less in the blood, the
Regarding distribution of the diuretic in hypoalbuminemia, is there any difference compared to a normal albuminic patient? Suppose you're giving a diuretic, is there any difference in the distribution?
volume of distribution in case of usually it is plasma protein bound, so the volume of distribution is less in case of normal protein. If it is hypoalbuminemia, there will be volume of distribution will be much higher, so the delivery of the diuretics to the site of action will be reduced in case of hypoalbuminemia.
The volume of distribution is higher in hypoalbuminemia. The amount of diuretic which you give, you want it predominantly to remain in the intravascular space. You have to be going to interstitial space where it doesn't have action. So you want it to be in the intravascular space. That's why you want to give resistant patients who are not responding to diuretics. You can sometimes give this one also. Okay.
You are answering very well. I'll ask some few questions. Okay. What are the experimental models of membranous nephropathy?
Hayman nephritis rat model. So they have used antigen, that is FX1A antigen against the proximal tubular fraction that act against the megalin. That was introduced in the rat, either active in or passively. That is passive means it was introduced again into another animal and the sera of that animal was introduced into the rat. So the antibodies will be produced and this will act against the megalin as well as the podocyte, which also contains the same antigen. But this was later found that the antigen is present in much concentration in humans. Later on, there is the after that there was the bovine serum albumin model. Here they have introduced the from the milk antigen was introduced into the animal, and then which also again produced membranous nephropathy. Then some rat model and pig model was there. Some neutral endopeptidase rat model was also present, which again because of the deficiency of the MME enzyme, there is antibody formed against this neutral endopeptidase, which is also implicated in the alloimmune nephropathy or the neonatal nephropathy.
Okay. Good. Okay. What is the 1/3 rule in membranous nephropathy? One-third rule in membranous nephropathy?
In membranous nephropathy, 1/3 of the patients can undergo spontaneous resolution. 1/3 patients will have a persistent proteinuria, and 1/3 can go for ESR, I mean progression of the CKD.
Okay. 1/3 will have the first 1/3.
First one, resolution can occur.
By,
Spontaneous resolution.
when?
In membranous, usually occurs by
Why you wait for 6 months?
for the spontaneous resolution.
Then what are the poor prognostic factors in membranous nephropathy?
One is the nephrotic, that range, I mean level of proteinuria,
Okay.
and
How
presence
much?
of
how much?
Nephrotic
more
range
than?
of proteinuria more than 3.5. If it is very
Poor
high,
prognosis.
10 gram of protein, more than 10
8,
gram.
8, okay. Okay, then?
Then presence of GFR decline at the time of presentation,
Yes.
presence of hypertension. Then if it is secondary membranous again, then if there is in biopsy picture, if there is any FSGS lesions, IFTA, and
Sex.
age of the
Sex of the patient, any male, female?
female has got a better prognosis.
Yes, female better. Is there any role of anticoagulation or antiplatelets in nephrotic syndrome?
Depending on the level of the albumin and the thromboembolic risk, if the level of the albumin is less than 2 gram per deciliter by using the bromocresol purple method or the less than 2.5 in bromocresol green method, then we have to assess the if there is any risk for venous thromboembolism and also assess the bleeding risk. If the bleeding risk is there, we can give aspirin alone. If the bleeding risk is not there, we can give the low molecular weight heparin or warfarin. Again, if the albumin level is less than 3 or 3.2, we have to assess the arterial thromboembolic risk, and if it is present, we can give aspirin. If not there, no anticoagulation or antiplatelet is required.
Okay, what are the trials in membranous nephropathy?
First one is the GEM-Ritux trial. Here they have compared rituximab and supporting measures and antiproteinuric measures versus that of the antiproteinuric measures itself. And they have found that there was better remission in case of using rituximab. Then the second trial is the MENDO trial. Here they have compared rituximab versus cyclosporine. So when they have compared the complete remission and partial remission percentage, at 6 months it was found that the remission in case of cyclosporine was more. But at 12 months, it was found to have a similar efficacy. But after the 12 months, the rituximab was found to have a better complete remission and partial remission rate as compared to the cyclosporine. Then there is a Starman trial. Here they have used the sequential treatment with the tacrolimus versus and rituximab versus the Ponticelli regimen. And here it was found that the Ponticelli regimen was
Starman is what?
Sequential treatment with the tacrolimus and rituximab versus that steroids and cyclophosphamide. It was found that Ponticelli regimen was better as compared to better remission rate as compared to the other regimen. Then Ricyclo, again rituximab, 2 doses was compared with that of the cyclophosphamide and steroids.
What
Again,
was the dose of rituximab in that?
in Starman trial, it was 1 gram at the end of 6 months. Whereas in the Ricyclo trial, it was 1 gram on day 1 and day 14. 2 grams
doses.
total.
2 doses.
2 doses.
Okay, what is rituximab? What is rituximab?
It is a monoclonal chimeric antibody against the anti-CD20. So it binds to the CD20 of the B cell, and the action occurs by when it binds to this the B cell, toward the FC portion of this rituximab. The complement factors can bind and can cause the complement activation and complement dependent cytotoxicity. Or else to this FC portion, the other Fc gamma receptors of the other cells like neutrophils, monocytes or natural killer cells can bind and can cause the lysis of the cells. And also it causes
continue.
It causes this cross-linking of the CD20 and can cause apoptosis of the B cells also. In case of proteinuria, I mean nephrotic syndrome, rituximab act by stabilizing the SMPDL3B, that is sphingomyelin phosphodiesterase acid like 3B, and thereby stabilizes the actin cytoskeleton.
Okay, this is anti-CD20. Is there any novel better
Obinutuzumab and ofatumumab. Obinutuzumab is partially humanized antibody. Ofatumumab is fully
it's not partially
humanized.
It's fully humanized.
Ofatumumab is fully humanized. I mean human. Obinutuzumab is humanized.
Both are fully humanized, no? Okay. Is there any other? Belimumab, is it? Is there
That
any
is
trials with that?
the BLIS and BAF inhibitor. That is again
That's
acting
also
against the
there.
B cell.
Okay, what about the, you said about antibody titer, no? Which antibody is used in diagnosis of membranous nephropathy?
Primary membranous nephropathy, anti-PLA2R has got around 80% sensitivity and 99% specificity. The other antigen antibodies are also coming up like thrombospondin 7A domain, then NEL1, then exostocin, semaphore, NCAM, etc.
Which was the first one?
Thrombospondin, but
Neutral endopeptidase.
thrombospondin.
No, neutral endopeptidase was the first
Yes.
detected. Okay. And what is the percentage of antibodies PLA2R?
PLA2R in primary membrane is around 80 to 90%. And thrombospondin around 1 to 3%, or in 10% in primary membranous nephropathy without anti-PLA2R.
The second most common is?
NEL1.
NEL1, okay. NEL1 is particularly in which conditions?
Can be seen associated primary, can be seen associated malignancy in 30% of the cases. And heavy metal
drugs.
induced.
Okay. What are the genetic causes of nephrotic syndrome?
Genetic, it can be
In
adults. Adults, usually the autosomal dominant forms will be seen in the adults, usually associated with CD2AP mutation, TRPC6 alpha.
Most common is?
In adults, TRPC6.
Most common. Or is it podocin?
Podocin usually in the infantile age group, since it is autosomal recessive.
Is there any proposed novel classification for membranous nephropathy?
Classification.
Usually we will classify as primary and secondary. Now, is there any proposed classification?
Based on the antigen, planted antigen.
Based on the antibodies. Okay. Which vaccine you give for nephrotic syndrome patients? First? Pneumococcal. You said about, sir asked about urine findings, no? Is there any other finding typical of nephrotic syndrome?
Maltese cross bodies. That is within this oval fat bodies. When we see under the polarized microscopy, there will be lighting up of the lipid crystals, which is seen as a cross pattern.
How will you choose which patients has to be treated initially, or whether you can wait in membranous nephropathy?
Based on there is a risk categorization. Yes. So based on the proteinuria and the other risk factors associated. If the patient is having less than 3.5 gram of proteinuria, normal GFR.
4 classes.
4 classes.
Yeah.
Low risk means if the patient is having less than 3.5 gram of proteinuria and GFR is normal, or else if after 6 months of antiproteinuric therapy, the proteinuria is again less than 3.5 gram and more than 50% decline of the proteinuria from the baseline, and normal GFR comes under the low risk category. Then the medium risk category, if the proteinuria is more than 3.5, or if there is a less than 50% decline from the baseline, or if it is not satisfying the high risk criteria, comes under the medium risk. High risk if the GFR is less than 60, or if the proteinuria is more than 8 gram and in 6 months, or if there is any other associated risk factors like albumin less than 2, if the PLA2R antibody level is more than 50, or if there is a higher level of alpha-1 microglobulin IgG in such case, and the selectivity index if it is more than 0.2, that all those conditions it will come under high risk. And very high risk will come with the complications of nephrotic syndrome.
Some other features are also there, no?
IgG1 level more than 1 microgram per minute.
Very high risk.
Alpha-1 microglobulin, then beta-2 microglobulin, selectivity index, albumin, and anti-PLA2R antibody levels. Then very high risk is life-threatening complications, or if there is a rapidly falling GFR and without any definite cause.
So in this case, how will you treat?
Here the patient comes under the high risk category because his eGFR is at that time was around 157 only, so less than 60. Then the proteinuria, he is saying that he lost around 9 gram of protein. Again, it will be more than 8. So it comes under high risk.
So you will start?
Here in this patient, in high risk category, we can either start with rituximab or we can go for a modified Ponticelli regimen. Okay. Here in this patient, he is in older age, more higher risk of infections, and life-threatening complications not there, so we plan to start with rituximab.
You're talking about membranous primary and secondary now. So you tell me how you differentiate that primary and secondary. You go first by clinical, light microscopy, IF, EM, each one.
Clinically, in primary membranous nephropathy, both can present with the nephrotic syndrome only. In secondary, there will be associated other symptoms Like if it is associated with plasma cell dyscrasias, patient will be having a loss of weight, bony pains, or if amyloidosis, there will be features of peripheral neuropathy, autonomic dysfunction, and other skin lesions. Or if it is autoimmune, there can be rash, joint pains associated. Or if there is any drug intake or any exposure to any heavy metals and any infections also. In light microscopy, in membranous nephropathy, in the early stage, there will be, in the stage 1, there will be no defined picture in case of light microscopy. In the other stages, there will be a thickening in the basement membrane. And also in the silver stain, we can see the spike appearance and the vacuolated appearance. And it does not have any proliferative changes in primary membrane nephropathy. Whereas in secondary membrane nephropathy, they can have a mesangial hypercellularity, mesangial expansion can be there. And if it is infection related, can have endocapillary hypercellularity. That is in LM. IF usually in primary membrane nephropathy, we can have a granular, diffuse and uniform granular deposit, capillary wall deposits of IgG will be seen. Whereas in case of secondary membranous nephropathy, we can have other deposits like IgA and IgA if associated with IgA nephropathy, or if it's infections, we can have other immune deposits and complement deposits. And the subclass of IgG, it will be IgG4 in case of primary. In secondary, we can have other subclass like IgG1 and IgG3. In electron microscopy, we can have podocyte food process effacement diffuse can be seen with the membranous nephropathy, and subepithelial dense deposits can be seen. Whereas in secondary membranous nephropathy, we can see other deposits like mesangial deposits and subepithelial, endothelial deposits, and have only focal food process effacement.
You have done a PLA2, or you said it's positive.
Negative, sir.
It was negative. Okay, now you have done a kidney biopsy and it's positive. So which is more sensitive, is blood or renal, and why?
It is said that both have a similar sensitivity and specificity. If one is available, the other is not usually necessary. But PLA2R, again, we have to see for the prognostication and for if we are going for transplant. In such cases, PLA2R important.
But this patient was negative PLA2R, no?
Yes.
When a biopsy, it shows staining. What's the reason? How do you explain that?
Biopsy, sir.
Biopsy is showing PLA2R positive.
Because in the early stages, the antibody titer may be very low, so it may not be detected by the methods, or else because of the difference in the assay, like in the immunofluorescence or ELISA method, or else the initial antibodies will be taken up by the kidneys can act as a sink to take up these antibodies. It may not be available, and also the difference in the fixatives can cause absent PLA2.
Okay, good. You got more time? Got more time? We'll ask more questions.
5 more minutes, sir.
5 minutes, sir. Okay, so a lot more questions. Sir. Okay, now you tell me now about minimal change in FSS. Again, the same thing about the light microscopy. Now, one is classically minimal change, and the other one is they're saying you cannot exclude. Okay, now is there any other methods to differentiate this one? Minimal change in FSCs. What are other methods?
We can use the urinary markers also. In case of MCD, there will be increased levels of the CD80, angiopoietin like 4, IL4, IL13, IL8, all this can be increased. Whereas in FSGS, there will be increased levels of this SUPAR will be there, nephrin, podocalixin, then TGF beta will be present.
Okay. Anything little more simpler? This is a urine, simple test. It's a classical proteinuria and minimal change.
Protein.
What is the classical description of proteinuria and minimal change?
Nephrotic range proteinuria.
So some description, no? The protein. Selective proteinuria, no? Selective. What is that? What is selective proteinuria?
Selective means if there is a loss of proteins other than this albumin or transfer in the urine, like immunoglobulins, larger molecular weight immunoglobulins. It is calculated by the selectivity index, which is equal to urine IgG by serum IgG divided by the urine transferrin or albumin divided by the serum albumin. So if it is less than, normally it will be less than 0.1 if it is selective. More than 0.2 it is non-selective. There will be loss of larger proteins in the urine.
So here the biopsy has come as minimal change. But under selective protein has come as 0.3. What do you think?
Maybe we have missed an FSGS in the biopsy.
In FSGS, the protein is not that selective. Okay. All right. That's simple test. Then what you said is CD80 is good. Where is CD80 located usually? Where is the CD80 antigen located?
CD80 is normally it is present in the antigen presenting cells, but in case of nephrotic syndrome, it will be expressed on the surface of the podocytes. And also when there is increased expression in the podocytes, in a case of MCD, there will be a that it will be expressed from the surface of the podocyte, will be released into the circulation.
Okay. All right. Any other more sophisticated test you would like to consider again to differentiate this minimal change in FSCS based on the pathogenesis?
By the serum markers,
So essentially, what is the difference between minimal change and FSCS? Pathogenesis.
podocyte number will be lost in case of FSGS, whereas podocyte number will be preserved in case of MCD. And the
Most important pathogenetic cause for minimal change is dash.
podocyte food process effacement.
Due to dash.
Because of the change, because of the abnormalities in the cytoskeleton.
Due to dash.
There are different theories for MCD.
Simple
One
theory,
is
simple
that
theory.
T cell mediated.
Complicated, simple theory. Why are you getting this food? Why are you getting this food process effacement? What is the pathogens? No, food process are like this, no? What happens in minimal change? The podocyte food process come like this. What causes it to come like this?
Because the shape of the podocyte food process is maintained by the actin cytoskeleton. So loss of.
But why minimal change has something?
Uh,
Any other pages? Any other pages would like to say? Simple thing, no? Any other pages would like to say? All because of loss of negative charge, you know. All this what you have said is all because of loss of negative charge, you know, the podocytes. So the podocytes are kept like this way because they are all full of negative charge and they repel. When it's minimal change, what happens is you get loss of negative charge. So now that repelling force is lost, so they fuse. So that's what you get the podocyte. So that's what. So all this thing which you mentioned of the selective proteins, all albumin is because of loss of negative charge. So again, how you will measure this negative charge? There were some stainings, no? So it's called synaptopodin staining, proteoglycan staining. All the stainings can sometimes. Even the staining for negative charges are also. So that will definitely that is loss of negative charge. That's the essential difference. No? Minimal change it is loss of negative charge. When FSC is not like that. Okay. We will come to person is having resistant edema. See, okay, resistant edema. How will you manage? What are causes and what will you? Patient nephrotic syndrome is coming with significant edema.
Maybe after treatment, maybe patient is having a diuretic resistance because of the nephrotic syndrome. There will be GI edema, so the absorption of the diuretics will be less. There will be maybe having some interaction with the food during the absorption, or maybe because of the hypoalemia, there is reduced delivery of the diuretics to the site of action, and also the uremic toxin.
What's the main cause of diuretic resistance? Initially, there's good response, but later they develop a response. So secondary, what's the main reason?
Because secondary sodium retention can occur because of the initial diuretic effect will be lost because of the sodium retention by the activation of the RAS system, sympathetic system. Diuretic breaking.
Right, but not the exact answer. So the main reason for secondary resistance in diuretic is dash.
Renal vein thrombosis.
No. To compensate for increased absorption of sodium in the distal tubule. You take a kidney biopsy before giving a diuretic, and after giving a diuretic, you find that the distal tubule cells become hypertrophied. Lot of mitochondria are seen after giving diuretic for a prolonged period. Because the distal tubule normally you get only 5% sodium reabsorption. But when you give a diuretic, loop diuretic for a long time, this reabsorption there goes to 10 to 20, 15%. So that's one of the main causes of diuretic resistance. So that it increases more. Because loop diuretics act on the loop. Now this is distal to loop, increased sodium reabsorption. How will you tackle that?
We can give sequential blockade of diuretics using thiazide diuretics.
So give thiazide along with that. So it's out on okay, you want to conclude? Okay, so I thought you did pretty well, did quite well. So I'd just like to make a small comment from this thing is that see now for the exam, some examiners wanted to give the syndromic diagnosis, then they want to give a morphological diagnosis, or sometimes they want to give the etiological diagnosis. Now this patient, again for nephrotic syndrome, because you had the biopsy report, but if you're seeing this patient, you will not be given the biopsy for the exam. You'll be seeing this patient for the first time. So that time, so that patient doesn't have much of edema. but then frothing of urine is there. So to go into nephrotic syndrome is a bit difficult. I mean, see, because the examiner say when you're seeing the patients, there's not much of it. So when you're bringing the diagnosis, nephrotic syndrome is a bit difficult. So the only thing which you got is frothing of urine. So proteinuric illness could be tubular, this thing also. But if you have got the patient who's got significant edema at that time, or that history should be there, the person got significant edema, to say nephrotic syndrome. Okay, so that's nephrotic syndrome. If you're saying that the diagnosis is there, the person got significant edema, then you can make a diagnosis of nephrotic. Otherwise, clinical diagnosis of nephrotic syndrome is difficult in this patient. So okay, so now you have made a clinical diagnosis. So here I would just put as proteinuric illness, again different diagnosis between a glomerular and tubular, because not much of edema in this patient. No? So at the time of the exam, if you say nephrotic syndrome, then the examiner will say, oh, this girl has got a tick. Right, so the first thing is that unless the person got significant, or you should be given that history. Okay, if you are saying adult onset nephrotic syndrome, then comes the morphological diagnosis. Morphological diagnosis here would be, again, it would be difficult in this patient, because to say membranous as first thing, it would be difficult. So here we would go for, this is patient has got adult onset, suppose let's say adult onset nephrotic syndrome, possibly a non-proliferative glomerular disease, because now that's, you're safe, there's no hematuria, so the examiner is okay. This is a non-proliferative glomerular disease. Of the non-proliferative glomerular diseases, I would like to consider primary first. Of the primary, membrane is the most common at this stage. I would also like to consider secondary, because in this patient, again, secondary is very important, like 65-year-old person. No? So see, of the secondary, I would like to consider a plasma cell disease, myeloma. If you see this patient for the first time, before membranous, I would think myeloma. For 65-year-old, without much edema, significant proteinuria, so myeloma. Okay, so that otherwise, you did quite well. Any comments from Vineetha?
You have presented very well and answered very well. Good.
Thank you.
Thank you, Chairpersons, Jacob George Sir and Vineetha Madam, for the excellent case discussion. Now, I would like to invite Dr. Naushad Sir. Sir is a HOD, Kozhikode Medical College, to come to the dais for honoring the chairpersons. I request the chairpersons to give a token of appreciation to Dr. Gopika for her excellent presentation. Thank you all. So we'll start off with the quiz prize distribution for the quiz. I would like to invite Srijit sir. The first prize is cash prize with the comprehensive textbook of nephrology, which is sponsored by Sun Pharma. Second prize goes to Dr. Govin from Alleppey Medical College and Dr. Soni Solomon from Trivandrum Medical College. For the second prize winners, we again have a cash prize. Third prize, we have Team A, Dr. Adul. We have a consolation prize for Team B as well, Dr. Prinink and Dr. Hajish Mohan. Dr. Prinink and Dr. Hajish Mohan. Thank you, Srijit sir. Now we have the winner for the case presentation. I would like to invite Naushad sir and Jacob sir for giving the prizes. First prize goes to Dr. Gopika. She is a senior resident from Kozhikode Medical College. She gets a cash prize and comprehensive textbook of nephrology. Congratulations, Gopika. She has secured 299 marks from the 4 evaluators. We have a runner-up as well. The second prize goes to Dr. Manoj. Manoj is a senior resident from Trivandrum Medical College. He also receives a cash prize. Thank you, sir.